So good morning. I'm very delighted to see new and familiar faces, mentors, fellow civil servants, leaders in the private sector, patient champions, civil society, and local governments. So in the next 15 minutes, I will introduce a PIDS Health, Economics, and Finance program, explaining the rationale behind this initiative and discuss the activities to assist our implementing agencies, PhilHealth and the Department of Health, and move us closer to achieving the universal healthcare. You might be wondering why is PIDS a government think tank that covers a wide range of sectors from education, agriculture, infrastructure, tourism, now creating a research program focused solely on the health sector. Here, we provide 3 of the many reasons. First, the rising income levels. The rising income levels will increase demand for high-quality healthcare services. So the Philippines is projected to reach an upper middle income country by, now it's 2026, but it's supposed to be 2025, over the past 2 decades. GDP per capita has steadily increased, hence bringing greater expectation from the rising middle class. The middle class will demand better healthcare, higher quality services, more responsive care, and a more institutionalized and a less fragmented health system. Second, the government is poised to become the dominant source of health spending, and this will have huge implications for private providers. Public spending on health in the Philippines is rising rapidly. As income grows, so does the government's share in health spending, a common trend in health financing transitions. In many countries experiencing health transitions or health financing transition, including the Philippines. The shift is driven by public demand for UHC and a stronger political focus on healthcare. However, increasing government health spending comes with fiscal and political implications. Third, PIDS projections in 2022 shows a significant rise in non-communicable diseases driven by aging populations and shifting epidemiologic patterns. As life expectancy increases, healthcare system must adapt to manage the growing burden of chronic conditions. The shift requires reform in the care delivery system and the way we finance our health system when we shift to non-communicable chronic conditions to ensure that the patients receive a continuous and comprehensive care throughout their lifespan. Primary care and integrated care models will be then the key to effective disease management. With these shifts, one of the many shifts, health has become an important political and economic agenda. These changes highlight the need for think tanks and research institutions like PIDS to ramp up health policy research, creating the Health, Economics, and Finance program dedicated to ensuring health policies. Informing these reforms are evidence-based, data-driven, and robust. So the RA 11975 and the PIDS board's resolution were the legal mandates for creating the Health, Economics, and Finance program. This became possible with the generous leadership of our president, Dr. Aniceto Orbeta, and the support of our board of trustees headed by Secretary Arsenio Balisacan. And we also thank our partners, DOH and PhilHealth, for this support. HEFP prioritizes 3 research areas in the short to medium term. So number 1 is rethinking our provider payment systems. Second is health sector performance measurements. And third is strengthening the culture of impact evaluation. The ethos of the health, or the ethos of the of HFEP are the following. Number one is we aim to establish a more strategic long-term partnership with agencies like PhilHealth and DOH. For PIDS, this type of collaboration, long-term collaboration, nurtures high quality and innovative research in lieu of like very sporadic short-term type of research. Second is it also give us the incentive to proactively address the technical needs of PhilHealth and DOH at that very moment. Second, and I think this is very personal to me, the program should serve as a training ground for early career economic and policy researchers, cultivating critical mass of expertise for the country. So when we try to understand the secret recipe of many countries that successfully achieve universal healthcare, is actually investing in the back-end technical experts. And I think we want to do the same as we transition to an upper middle income country. With this commitment, we at PIDS dedicated health team to work on the program, bringing together more than 20 researchers from diverse backgrounds, including physicians, economists, data scientists, epidemiologists, and social scientists. And around 75% of them are women. So now I want to highlight, so I'm a feminist, so so that was a deliberate attempt, but now I want to highlight our first focus area, provider payment reforms. So there will be some technicalities as I go along, but I hope you understand this. I think we need to explain the research focus. The first focus is provider payments. So I'll start with the perennial challenge that we always encounter. Out-of-pocket spending remains high, covering half of health expenditure and driving many Filipinos into poverty. And we've done many research on this at PIDS. I want to benchmark with, this might be controversial, I want to benchmark Philippines with Indonesia because we have many similarities. In terms of, Indonesia has a highly decentralized system like the Philippines, highly fragmented health financing system like the Philippines. We have so many financing sources, right? Supply side constraints because of the geographical challenges and the large private sector penetration. It's so similar to the Philippines. But Indonesia is experiencing a large decline in out-of-pocket in the last 10 years. While there might be facing some fiscal challenges that could be debatable, Indonesia has made significant strides in mobilizing resources for health, expanding benefits, organizing a painful fragmented system that we tried, and reforming provider payment systems, moving towards the DRGs. Another important problem is that PhilHealth declining financial leverage over hospital revenues threatens PhilHealth's ability to drive efficiency, quality of care, and patients' financial protection. Our analysis of PIDS hospital financial report, which try to collect a lot of financial statements, reveals downward trend. So PhilHealth provider payment system faces some weaknesses. That's why we see all these outcomes. Number one is issues in costing practices. Second is payment design and rate setting systems contribute to the inaccurate payment rates, unpredictable healthcare costs, and institutional mistrust. And to patients, this leads to lower financial protection. So we are here to help solve the problem. So what do we intend to do? So the HEFP is committed to data-driven, independent research to strengthen the provider payment system. This includes developing and updating diagnosis-related groupings, partnering with PhilHealth to institutionalize better costing standards and analyzing the potential impact of transitioning into diagnosis-related group as envisioned in the Universal Healthcare Act. Another key activity is conducting a forward-looking, every time I say forward-looking, they always like, but forward-looking researcher to support policy reforms under the Universal Healthcare Act. This includes exploring transitions to a global budget and analyzing claims data to perform business intelligence, assessing care quality, which is essential as we transition. So as you transition into DRGs and global budget, quality of care becomes more and more important. But we haven't really thought about it, right? So I think we need to start looking into this as we transition. Okay, most ASEAN countries, or our neighbors' health system, Thailand, Indonesia, Vietnam, and Malaysia also, along with many European countries, Australia and the US CMS, are now using DRG-based provider payment system. So I want to explain a little bit about DRG because I think this is important. So let's look at a fair payment example under a DRG. So I will provide two examples. One, a healthy teenager, I should say, and his lolo who has hypertension. Both have dengue without warning signs. One, the younger patient, was treated at a level 1 hospital and recovered in a day, while lolo required care at a level 2 facility with close monitoring to prevent severe dengue. Under the current ACR, both would receive the same fixed rates, 10,000 pesos. This is just a sample number for ICD-10 A97.0. However, under a DRG adjusted payments, based on case complexity, one case with no complication with DRG 1856 would receive 6,000 pesos, while lolo with moderate complication, DRG 1856.3 would be reimbursed 25,000 pesos. In summary, DRG factors in risk-adjusted costs, considering secondary diagnosis, procedures, patients' demographics, length of stay, discharge status, and even newborn birth weight, grouping cases with similar clinical characteristics and resource needs. We also tried to understand the governance structure of how countries implement DRG. A clear governance structure is essential to DRG implementation. We propose a 5-step approach based on established systems worldwide. Payment rate calculations like the Thai Case Mix Center, the Germany's Institute for Health Remuneration, or Australian Pricing Authority can be managed by an institution, a research institution separate from PhilHealth and UH. The PhilHealth board with UH to set the policy direction for DRG as per the UHC law. Second is that PhilHealth will set a relationship with stakeholders so that hospitals, health professionals, and patients to ensure that DRG development is transparent and collaborative. Third, this institution takes the lead in doing data analytics and the grunt work, basically, and processing stakeholders such as the medical societies and academia's input. And this leads to a 4th step of reporting these back to stakeholders through an iterative consultations to adjust the rates. And lastly, PhilHealth will take into consideration the recommendation of this group. It's still up to PhilHealth, given its budget constraints and other political or economic considerations. Transitioning into DRG requires significant technical work, and when we were discussing this with our partners in the region, it is actually very complex. Transitioning to DRG requires significant technical work, initial step, policy development, DRG adoption, and pilot calculations using PhilHealth claims data, we are underway. We're currently working with PhilHealth on this. However, key tasks remain refinements, recalculations, and consultations, which can only proceed once PhilHealth collects data from the new claim form 5. PIDS has already developed a version 1 of the DRG implementation manual for future adoption, but this could result into more refinements as we get more data, a better and clean data. And we want to thank the DRG experts and economists from the World Bank for helping us review the technical soundness of this. And obviously, our friends from the Thai NHSO. So collaboration is important for continuous progress in DRG, and that's one of the things that we've learned. Medical societies and academia validate clinical algorithms, while potentially healthcare providers participate in costing studies for us to have a robust understanding of the payment rates. Okay, so I'll move now into the second focus area of the program, governance. And I think this has been a challenge, right? Assessing healthcare performance remain a challenge due to insufficient data. And as researchers, we always encounter this, like, are Filipinos healthier in local government 1 or in local government 2? How much is the government spending in local government 1, in local government 2? And are there disparities across local governments in terms of these inputs? The same applies for healthcare facility and workforce distribution. And the theory of change here is that addressing these gaps could be done through improving accountability and resource allocation. So what do we mean by this? So how can we help on this front? So the program aims to independently generate data to inform governments, civil society, and the public. The PIDS team has dedicated, so out of the 20 researchers, the PIDS team had a dedicated data team that regularly analyzes health data from various administrative sources. And I kid you not, it's very fragmented. Apparently, it's very, very fragmented, and we try to consolidate them. And we conduct sectoral performance using these data at the local government level and plans to develop data visualization to a broader audience. Now, I want to discuss briefly our third focus area, which is impact evaluation. And I think this is my last slide. So PIDS, in general, promotes evaluation of government programs and projects, a priority backed by NEDA or DBM. So collaborating with agencies like PhilHealth, we've assessed, and many multilateral organizations, we've assessed key programs like Pantawid Pamilya, Social Protection Program, infrastructure projects, leading to policy improvements. So over the past 5 years, we've expanded this work to health, evaluation of the National Immunization Program, tobacco control programs, early childhood care programs, and capital investment programs. So in this program, we want to strengthen our commitment to evidence-based policymaking by continuing the traditions of evidence-based evaluation of its effectiveness. So I think this is my last slides, and I would like to thank again everyone for joining us today to launch the health financing and economics. Sorry. Health economics and finance program. So sorry. So thank you very much. Thank you.